இது வருங்க வேர்ல்ட் கிரேட்டஸ்ட்
இந்த மாதிரி கண்டமேனிக்கு பொய்யெல்லாம் அடிச்சுக்க கூடாது. I am going to demonstrate binocular indirect ophthalmoscopy. I feel there may be some difficulty for ophthalmologists who are practicing direct ophthalmoscopy to switch over to binocular indirect ophthalmoscopy. But by mere practice, constant practice, one can master binocular indirect ophthalmoscopy, and they will love doing indirect ophthalmoscopy to examine retina. Now what follows is I am going to do a simple demonstration of binocular indirect ophthalmoscopy. Now what you are seeing is the instrument binocular indirect ophthalmoscope. Now I'll demonstrate each and every part of the instrument. There are two types of indirect ophthalmoscope available. This one is a headband type. Now I am going to demonstrate the instrument to you. Here you see the headband's cross strap, which will hold the weight of the instrument. This can be put over the surgeon's head, and this is the encircling band which can be tightened to steady the instrument. And now there are various adjustments. This is the optical unit. To adjust the optical unit, this knob can be used to tilt the optical unit according to the surgeon's convenience. And these are the oculars, and this particular knob is to adjust the mirror so that when the ophthalmologist put the headband on his head, and to adjust the light so that the upper half of his view is illuminated with the light. And these adjustments can be done according to the IPD of the surgeon. Yeah. Now after surgeon wearing the headband ophthalmoscope conveniently, he has to adjust the illumination so that through the oculars, the illumination what you see should be in the upper half. Yeah. Okay, then over it. After wearing the indirect ophthalmoscope, the first adjustment, after tightening the knobs here, you should adjust the light by tilting this knob either up or down so that the illumination is in the upper half of the oculars through which you see. Here you see an adjustment for adjusting the intensity of illumination, the light, medium, and this is the strongest illumination. When a patient having a media hazy, you can keep the intensity at the highest level. The next important requirement is a table for examination. The table, there should be space around the table to move around, and the height of the table should be convenient to the surgeon who is doing the indirect ophthalmoscopy. Approximately it should be at the high level of the hip. The next important requirement is the room should be quite dark. There should not be any other light. Next is about the condensing lens to be used for indirect ophthalmoscopy. There are various types of lenses available, plus 20, plus 14 and plus 30. The commonly used is plus 20 aspherical lens. The convenient lens is Nikon aspherical, what you are seeing now here. Usually the convex part is towards the surgeon and the flat surface is towards the patient. It is usually indicated by white line. And it's held by the thumb and the index finger as shown here. Now the patient is made to lie comfortably. There is no pillow used, and the patient is explained what we are going to do. That we are going to use the lens and a light to see the interior of the eye. The next requirement is a good pupillary dilatation should be there, and the room should be quite dark. And the head of the patient should not be either extended or flexed. It should be just lying straight. And ask the patient to see wherever you want to. If the patient is not able to see properly, you can ask the patient to see their own hand, whatever position you want to, either to look straight this way or the other way. Accordingly, the eye can be moved. Now with the indirect ophthalmoscope, headband indirect ophthalmoscope, both the hands are free for the surgeon. With one hand we can hold the lens, and with the other hand we can open the lids, as you see here. For focusing on the fundus, first the surgeon keeps the lens close to the eye, sees the cornea and the pupillary area, then slowly raises the lens to focus the retina. Once you get the retina, you adjust the lens so that you avoid the other images, other reflexes. And first, to see the patient, you can ask the patient to see their own finger to focus at a point. And if you want to look up, you can ask the patient to look up like that. And to examine the 12 o'clock meridian, the doctor should be at the exact opposite meridian in this way. And the ophthalmologist should go around the patient to examine the entire fundus in various directions. With the indirect ophthalmoscope, you can examine beyond equator and with depression ora serrata. Now we are going to demonstrate the axis concept. Here, a line drawn from the mirror illumination from the indirect ophthalmoscope, and which passes through the center of the lens and the center of the pupil and the fundus. This should be always in a straight line. Wherever you are examining, say when you want to examine another meridian, the surgeon moves, and you can see the same. The lens also moves, and also the eye moves, so that this line axis concept is maintained throughout. If you are going to examine the 12 o'clock meridian, the surgeon should stand at the 6 o'clock from lower inferiorly. And the same way, the surgeon examining the 6 o'clock as shown in this picture, the surgeon should be at the 12 o'clock. Like this, the entire periphery of the fundus can be seen. Here we are showing the correct method of focusing. Now you see the entire picture in the whole of the lens. If they begin initially, any ophthalmologist beginning an indirect ophthalmoscope can have difficulty. If they are seeing only part of the image in the lens, that means the focus is not right. The image should fill the entire lens as shown in this picture. Then only there is a correct focus, and you are following the axis concept to examine the entire periphery of the fundus. And the person who is examining should always have it in mind that you see a double inverted image, left to right inversion and upside down inversion. You may have difficulty in orienting with the part seen by the indirect ophthalmoscope. And in this picture, here you see attached retina and detached retina in one view. And when comparing with the direct ophthalmoscope, you can, using indirect ophthalmoscope with plus 20 diopter lens, you can see an area about 37 degrees, a wide area at a time. Here in this picture we are showing using the scleral depressor to see the ora serrata. There are two methods shown here, one holding with the thumb and other putting thimble in the index finger. Now you are seeing the method of doing the scleral depression. The patient is to depress at 12 o'clock. The patient is asked to look down, and the scleral depressor introduced between the upper lid and the orbit, and then the patient is asked to look up, and gentle depression is done, and to see the ora at 12 o'clock position. Now what you are seeing is the temporal ora serrata, which you can see by scleral depression. You can see the retinal vessels ending and the ora serrata. And now this is nasal ora serrata. Here you see the retinal vessels ending, and this is the nasal ora serrata. Now you see a red lesion in the retina. Without depression, it looks like a red heme. But in the next picture below, with depression, the retina appears pale, and the red lesion now appears the bright red color. That indicates it's not a heme, it's an open, a retinal hole. After mastering scleral depression, one can start drawing. Here you see a drawing sheet. First you write the name of the patient, the number of the patient, and the date, and usually you put your initials here and mark which eye you are going to draw. And before starting the drawing itself, you can mark the disc on the left half of the page as shown here, and this line indicates equator, the next outer line indicates ora serrata, and the other one indicates the margin of ciliary process, pars plana area, and the clock position is marked. This 12 o'clock is placed towards the foot of the patient, and 6 o'clock is placed towards the chin end of the patient, and this drawing sheet is kept over the chest of the patient. And first you mark with a pencil and label all the lesions profusely. After mastering scleral depression and mastering indirect ophthalmoscopy, one can start drawing. Here you see a standard drawing sheet. First, the name of the patient is written, number of the patient, and date is mentioned. Next, you put your initial before starting the drawing and indicate the eye to be marked. Here, the left eye OS is marked, and before starting the drawing, left eye optic disc can be marked in the left half of the page. And usually, this 12 o'clock meridian is kept towards the foot end of the patient, and 6 o'clock to the chin end of the patient, and it usually kept on the chest of the patient. And you generally draw whatever you see. There may be problem in representing a sphere on a flat surface. By doing number of drawings you can master. Drawing improves the skill of indirect ophthalmoscopy. First you have to see the fundus, and interpretation can do it after making the drawing. And you always use accepted color coding and mark all the lesions profusely. And this drawing serves as an important record, and anytime a colleague's opinion can be sought with this drawing. No, you're not saying that. Now what you are seeing is normal retina. This is ora serrata, optic disc, macula, and vessels. Now we are seeing lattice degeneration here. It is characterized by sharply demarcated, circumferentially oriented areas of retinal thinning, most frequently situated between the equator and the posterior border of the vitreous base. Next, here you see hyperplasia of the retinal pigment epithelium is frequently associated with lattice degeneration. Here you see radially oriented lesions which may extend posteriorly to the equator. Here, along with the lattice degeneration, you see atrophic retinal breaks. This is lattice with open. Here you see another variant of lattice degeneration which is called as snail track degeneration. Next, here you see acquired retinoschisis. You can see the retinal vessel elevated. Here what you see here is called wide width indentation. It's usually commonly seen in normal eyes on scleral indentation. The retina sometimes has the same appearance without indentation. That's called white without pressure. Here you see pigment clumps. Here you see atrophic holes in chorioretinal atrophy. This shows paravascular vitreoretinal attachments may predispose to retinal tears in that eye, develop acute posterior vitreous detachment. This picture you see snowflake degeneration which can be associated with lattice degeneration. This shows paving stone degeneration or focal chorioretinal atrophy which is usually seen in normal individuals. This is reticular pigmentary degeneration which is frequently observed in elderly patients. These are all equatorial drusen which are seen in the elderly. These are also again seen in elderly patients or oral chorioretinal degeneration. This condition is seen with increasing age. It's called cystoid degeneration. Here you see a horseshoe tear with subclinical retinal detachment, localized detachment. Here you see a large horseshoe tear with persistent vitreous traction. Here you see a operculated large open with a bridging vessel across it. Here you see a round retinal tear with a free floating operculum. Here you see horseshoe tear surrounded by pigmentation. Another tear surrounded pigmentation which indicates that these are quite old tears. This is shows acquired retinoschisis. You can see the retinal vessels elevated. These are small asymptomatic holes. This again shows acquired retinoschisis with holes in outer layer of retinoschisis.
அதிகமாக எடுத்துக்கிறாங்க. ஆமாம், அதிகமாக எடுத்துக்க பரவாயில்ல, நிறைய எடுத்துக்கலாம். அது பக்கத்தில் வந்துட மாட்டாங்க, படம் போட்டோம் என்ன